Can you hear me now? Good. Thanks, sir. All right. So we're at Trussville Fire and Rescue today. Thanks for your help, guys. Appreciate the support. Today we got Dr. Degeare going to be talking about some abdominal emergencies, and Dr. Brown talking. When we're finished up, we'll switch over, get some lunch, go to the lab, do some cardiac arrest training, some airway management, some upcoming events. So the next EMS challenge will be in Enterprise. Next week is off cycle because a lot of folks are on spring breaks. We'll be in Enterprise next week. In April, the second Wednesday, we're at Birmingham Fire. There's nothing the fourth week because of FDIC. The other thing I wanted to mention was that the Group Care Transport Medical Conference is in Orange Beach, April 10th through 13th, I believe. But it's a pretty close, easy drive for those of you guys that want to kind of branch out and do some group care stuff. So, any questions, comments before we get started? Nobody making eye contact? Very good. All right. Again, we're in Trussville. If the areas come out, we got lunch around 11 and then skill labs after that. Okay. Bye. Got a bunch of folks coming in. Very good.
Very common presentation, one of the most common, if not the most. So before we get started talking about specific conditions, we'll start with the anatomy. So commonly, the abdomen is divided into 4 quadrants, right? Starting, if you start at the mid-xiphoid, at the xiphoid and go down, then if you start at the umbilicus and go across, that forms a right upper, a left upper, a right lower, and a left lower. Right upper quadrant, you're going to think a lot about liver, you're going to think a lot about gallbladder, you're going to think about pancreas, you're going to think about stomach. It does get, the right kidney is in the right upper quadrant. It is more posterior, so a lot of times they'll present more like flank back pain, but it does still fall into that quadrant. You do get some of the hepatic flexure of the colon, and just a little bit of small bowel as well as the duodenum coming off the stomach, first part of the small bowel. The left upper quadrant is not as exciting as the right upper quadrant, just less things that you typically present with abdominal pain. Biggest thing, stomach, the leftward portion of the pancreas, colon, spleen, and still that left kidney would fall into that category as well. Getting into the right lower quadrant, number 1, appendix. That's what you always want to make sure isn't happening. You're also going to start having reproductive organs. So you're going to have, in females, the ovary, the fallopian tube, in males, the spermatic cord, and potentially testes if they haven't descended. You'll also have a lot of small bowel and cecum. And then the left lower quadrant, you'll have the sigmoid colon, a lot of small bowel, as well as the same reproductive organs we just talked about. In both lower quadrants, you'll also have the ureters coming down from the kidneys to the bladder. And the bladder, whether it's a UTI or other bladder pathology, can present as either right or left lower or suprapubic pain. You can also split it up into 9 quadrants, which is probably what we more commonly do in the emergency department. Where you have the epigastric region, umbilical region, hypogastric, and then you have the right and left hypochondriac, lumbar, and iliac regions. Everything there, talk about all that. But so the differential for abdominal pain is very broad. We are by no means going to hit everything today. This is just kind of one chart that can kind of get you started as far as how to think about things. What do you think on this? I'll touch on a little bit of everything. But pain presentations can be atypical, right? So in the elderly, it can be atypical, right? Nervous systems aren't what they used to be. The muscles may be atrophied and might not give you as much abdominal rigidity in an acute abdomen, especially in females, diabetics, and the elderly. Abdominal pain could be from the heart, right? It might not even be abdominal in nature in the first place. So definitely something to consider in those populations. In the immunosuppressed, they might not mount this, the same immune response that UMU would. So that's something else to consider as well. And then in pregnant patients, there's a lot of, as you get farther and farther along, a lot of abdominal organs get displaced, so you might not have the classic presentations you're used to. For example, the appendix not being in the right quadrant anymore. So they list some do not miss up there. The ones they list are ectopic, AAA, perforated hollow viscous, bowel obstruction, mesenteric ischemia, acute pancreatitis, appendicitis, and MI. I'd argue there's plenty more. If you look down there, like I wouldn't want to miss ovarian torsion. I wouldn't want to miss a strangulated hernia, for example. But so we'll just kind of go differential diagnosis through the different quadrants and regions to start with, and then we'll kind of talk about pre-hospital approaches. So the right upper quadrant, we have biliary colic, which is just a fancy word for gallstones, and the discomfort you have from intermittent obstruction of the gallbladder emptying. Then acute cholecystitis, which is acute gallbladder infection, meaning that now the gallbladder has become blocked off and it's unable to empty, and now it's infected. Acute cholangitis, which is a much more severe infection of the entire biliary tract, usually caused by a stone in the common bile duct, which is now blocking off drainage of bile from the liver, from the gallbladder, potentially the drainage from the pancreas as well. And usually in older patients, it can be very, very severe. Acute pancreatitis, which you'll probably see very commonly. Hepatitis, liver abscess, pyelonephritis, and then pyelonephritis being kidney infection. And then lung pathology. It's with the lungs can kind of get down there a little bit on the right and left upper quadrant. So if you have a lower pneumonia, if you have a PE, if you have a pleural effusion, that could be causing discomfort that might present as abdominal pain. That might be their complaint when all along it's not anything that's causing their symptoms. So before I go to the next slide, if I go to the next slide, it'll show everything. So the next one will be epigastrium. So as far as the epigastrium, does anybody want to throw out a differential diagnosis or some of the things that they consider when they have patients with epigastric pain?
Esophageal varices,
Okay, that's good.
Acid reflux?
All right.
stomach ulcer,
Yep.
MI,
Yep. That's a good one.
pleurisy.
Mm-hmm. You're all good. You're doing it again today.
Done.
How about this side of the room?
Yeah.
Some of them might already be up here.
I have a hernia.
Sure. Yeah. And you are doing a great job. I don't have all of them on here, so if you don't see it on here, doesn't mean you're wrong, because these are all great answers. So we'll swing through. So I heard a reflux, right? I heard stomach ulcer, MI, atypical presentation is up there too. This is by no means at all, and all the options here. But so reflux could easily present as mid-sternal pain, could present as epigastric pain, gastritis, and peptic ulcer disease. Gastritis being more of a diffuse irritation of the stomach lining, rather than peptic ulcer disease, which is actual ulcers within the stomach, or just as common the duodenum, the first portion of the small bowel. Acute pancreatitis can present most commonly in the epigastrium, but it can present in all of the upper abdominal regions. Atypical presentation of acute coronary syndrome is definitely a big one to think about. If I have an older patient or a diabetic or somebody with a cardiac history that's coming in for epigastric pain, they're getting an EKG every single time. Now, so also when we're in this midline region, to start thinking about aortic dissection and ruptured AAA, they can present as diffuse abdominal pain or midline, which is something to start thinking about if you have a patient with risk factors, getting up there in age, tobacco use. Start thinking about those things. Does anybody want to take a stab at left upper quadrant?
No pun intended.
No pun intended. We're not doing trauma today.
Lift up the room.
Times.
I'm sorry. Pancreatitis, yes. So I think it's not as common, but it's on my list because if we still present over there. So this one's left upper quadrant is kind of the more the part, not to shame the left upper quadrant, but the least exciting, at least to me. There's yeah. So the biggest organ that's there is the spleen, right? If you, any problem with the spleen, if you have, let's say there's a sickle cell patient or a patient that's at increased risk of clotting, right? If you have splenic infarcts, it'd be really painful in the left upper quadrant. If you have a splenic abscess, if you have a splenic rupture, so let's say like a 16-year-old kid with mono who plays contact sports, right? If you that could easily be something that you get called to with left upper quadrant pain that if it's ruptured could easily spread to becoming an acute abdomen, which we'll talk about a little bit later. Splenomegaly, just the presence of, especially in sickle cell patients, splenomegaly could cause discomfort in the left upper quadrant. And then you kind of still have the other things that we've all talked about, right? You might have some gastritis, peptic ulcer disease that's causing discomfort in that region. Pylo, although like I said earlier, probably will more likely present as like flank or back pain, especially in the CPA region, which we'll get to. And then same things as the right upper quadrant, lung pathology, such as pneumonia, PE, pleural effusion could all cause pain there as well. So the next one is going to be right lower quadrant. Who wants to?
Sides.
There we go. All right. That's the number one thing we're all thinking about. We want to make sure isn't happening. Anybody got any other options?
Intestinal blockage.
Sure.
Strangulation of the intestine, hernias,
Mm-hmm. Sure.
ovarian issues.
Oh yeah. Now we're getting into like the lower quadrants and the pelvic regions, so you got to start thinking about reproductive organs.
You're in there, Trey.
Of course.
Kidney stones.
Mm-hmm.
Yeah.
Is that from experience? All right. So we have appendicitis. There's number one on there. So we have renal polyp as well, which is fancy word for kidney stones. We have ovarian and testicular torsion. On that, you could also have any sort of ovarian cyst that's ruptured, bleeding, increasing in size, that's causing discomfort. Any female of childbearing age who has abdominal pain, especially lower abdominal pain, ectopic pregnancy, definitely needs to be ruled out. It's something to always consider in these locations. We talked about UTI and then PID, which is an ascending pelvic inflammatory disease. So ascending sexually transmitted disease, usually gonorrhea or chlamydia, that starts working its way up, affecting the higher reproductive tract, the fallopian tubes, ovaries, could even lead to a tubo-ovarian abscess, like an abscess on the ovaries. That was something to consider. And then incarcerated or strangulated inguinal hernias, right? So inguinal hernias, whether it be direct or indirect, you could definitely start to cause discomfort in those regions. And definitely bowel obstruction causing strangulation could present in those quadrants. I have that under kind of like the diffuse one, but that could definitely cause local lower abdominal pain as well. I won't ask you for the left lower quadrant just because we have a lot of the same things, right? Because we are fairly symmetric as humans. Left lower quadrant, the one you start thinking about a lot, especially in your older patients, would be diverticulitis, which I'm sure you'll have seen plenty of times. Constipation could be a very simple reason. That could be more diffuse as well. So renal polyp, we already talked about. All the other ones we already kind of talked about, but they are all things to consider. And then diffuse. So one of these are your big bad things you want to rule out, right? So bowel obstruction, whether it be a small bowel obstruction, which is usually causing about 80% of those, or a large bowel obstruction causing about 20%. Anything that causes a perforation, whether that's perforated diverticulitis, peptic ulcer, aortic pathology. Definitely don't want to miss a rupture AAA. I definitely don't want to miss a dissection. Mesenteric ischemia. This can be acute, where you have an acute blockage of the arteries or veins that supply the bowel, or it can be chronic in nature, and you can just kind of have postprandial discomfort or pain after eating. Inflammatory bowel disease. This is your ulcerative colitis, your Crohn's. You'll definitely see a lot of patients with these conditions. Simple gastroenteritis, right? Going from above, going from below, having some abdominal discomfort with it. Very common, you'll see a ton of that. In specific populations, most commonly cirrhotic patients, you can get SPP, which is just spontaneous infection of the abdominal fluid. Malignancy cause a lot of different symptoms, right? Malignancy could cause obstruction, it could cause lead to perforation, it could just cause discomfort in and of itself, especially as it metastasizes. So something to think about. Talked about constipation, and then irritable bowel syndrome can cause a lot of these diffuse abdominal pain as well. Right. So pre-hospital management. This is kind of where it really gets into what you guys are thinking about every day, what you guys are doing. So what do you guys think about? What do you guys plan to do here that you're being called for abdominal pain? I'm sorry?
Like the stomach.
Yeah, of course. Physical exam. That's definitely a good one to do. That's on the list.
A lot of cardiac.
Mm-hmm. That's on the list too. Good.
Think about pretty much your primary assessment, just asking the right questions, like the patient pregnant, stuff like that. Just trying to figure out what stuff like that.
Exactly. Yeah. Getting a good history is vital to getting a better grip of what's going on. So number one, this wouldn't be an EMS lecture if we didn't start with ABCs. So airway, breathing, circulation. Airway and abdominal pain, less likely to be an acute issue. One I could think of that could be pretty concerning is if you have a GI bleed, especially a variceal bleed. That's where airway can start becoming an issue. We'll talk about that a little bit later, as well as if they're super obtunded or in shock and they're not protecting their airway. That'd be one other consideration there. Breathing. If there is lung pathology that's presenting as abdominal pain, they might have an oxygen requirement. Make sure they don't have equal breath sounds. Make sure that you don't see any signs of a pneumothorax that could be causing abdominal pain. Circulation. A lot of abdominal pain can present as shock, right? So if you have a rupture inside of pregnancy, that could present as shock. If you have a perforation that's kind of been sitting at home for a little bit, that could present as shock. If you have a massive GI bleeding, that's presenting as hemorrhagic shock. So definitely monitor your patients for signs of shock, and if so, treat them appropriately with fluids. Some of you often do push dose suppressors or like other drips as well with that. Vital signs, which you are going to do on all of these patients, right? If somebody comes to you all and they are tachycardic, they're tachypnic, meaning their heart is beating really fast, they're breathing faster than normal, they're febrile, right? That's going to point you toward this could be sepsis, right? If their heart rate is super fast and their blood pressure is very low, that would make you concerned about shock, right? Whether it's septic shock, whether it's hemorrhagic shock. Vital signs, especially in older patients, might not always be the most reliable, right? A lot of these patients can't mount the same response, and a lot of them are also on medicines like beta blockers that might not make them as tachycardic, so it might be harder to identify shock in an older patient, but something to consider. Keep them NPO, right? Especially if this is an acute abdomen or somebody you're concerned might need surgery. The last thing we want to do is let them eat a cheeseburger on the way in, right? IV access, you put a slash for IO access there as well if things are truly hitting the fan. That way, any interventions, which we'll get to in a minute, like IV fluids, and analgesia, antiemetics, stuff like that, you can help already start the treatment of these patients in the pre-hospital setting. So definitely have people say this, thorough history, right? This might be the most important one as far as like ever getting to the bottom of what's going on. It's just a really thorough history, and we'll kind of go through the components of that in a minute. But the history of present illness, their medical history, past surgical history can really clue you in for abdominal pain. Sometimes familial history, thorough physical exam, blood glucose. Again, on these patients, especially if it's a younger kid or somebody with diabetes, if their sugar is 700, they're puking, they have abdominal pain, could point you towards DKA. EKG. So if cardiac history, elderly patients, diabetic, females are more likely to have an atypical presentation of acute coronary syndrome. So definitely something to do on these subsets of patients. and then treatment, right? So IV fluids, if a lot of patients with abdominal pain are going to be throwing up, they're not going to be eating as much, they're going to be dehydrated, they're going to be volume down, especially if they're showing signs of shock when they get fluids in them. If they're bleeding, if they're in hemorrhagic shock and we have access to blood, obviously that'd be number one. But if all we have is fluids, then at least get that started. And then treating their pain, treating their nausea, will be very helpful as well. So a lot of you all probably already seen this, but this is something that we just want to make sure doesn't happen. So patient says it feels like indigestion, and then we have this, right? So definitely want to make sure we're not missing this. I actually just had a patient, I think it was at Gardendale the other day, where they had gone to their they had gone to some clinic for midline chest pain. It was like a 70-year-old dude, midline chest pain, and he got prescribed Carafate. And he came to us 3 weeks later, and his troponin was like 10,000 and had a 99 blockage of his left circumflex. So it can be indigestion, it can be gastritis, it can be reflux after you made sure this isn't happening. And those are the same populations we kind of talked about earlier as well. So pre-hospital, now we're going into history, right? So y'all probably heard of OPQRST. I think when I was at Jeff State, I heard several of y'all talking about that. But great way to get a history, right? So onset, when did it start, right? What were you doing when it started? Was it sudden or gradual, right? Was it sudden onset? Like, did you all of a sudden have a rupture of an ectopic pregnancy? Did you all of a sudden have a perforation, or has it been gradual, right? You've been having symptoms that have progressed over the last 2 or 3 days, like bowel obstruction. Provocation and palliation, right? What's making it better? What's making it worse? Have they tried anything at home? Medications, different things that they've tried to make it better. Does positioning make it better or worse? Does eating make it better or worse? Does going to the bathroom make it better or worse? Quality, right? So this is a big one, right? What does it feel like? Is it sharp? Is it dull? Is it constant? Does it come and go? I find myself asking patients this every single day, right? Just knowing if it's constant or it comes and goes can be huge, right? If it's constant, you might think about something that's completely different from if it's coming and going. If you have a kidney stone, for example, that's going to be more likely to be intermittent. It might always have some level of discomfort, but when those ureters get to squeezing, you're going to feel that sharp pain hanging off the side of the bed. So these are all different things that can really kind of point you in and help rule out different diagnoses. Where is it located? So region and radiation. So where is it? Does it spread anywhere else? For example, you might have the beginning of appendicitis might kind of be very vague, right? You might just kind of have periumbilical or just diffuse lower abdominal pain, and it might migrate with less presentation to the right lower quadrant. So getting a history like this can really help point you into what direction and what conditions the patient has. So severity, stressing that 1 is no pain at all and 10 is the worst pain you've ever experienced. That can kind of help give you an idea of how much it's affecting the patient. Timing, right? Is this something that's, it started off really bad, now it's getting a little better, or is this like consistently getting worse and worse? Is it unchanged since it started? And then I threw on associated symptoms as well. It didn't really fit with any of those, but a lot of other things that they're experiencing can kind of help point you into what's going on, right? So like nausea, vomiting, diarrhea, if they have fever, if they have jaundice, if they have vaginal bleeding, abnormal discharge, if they have pain or blood with urination, if they're lightheaded, pre-syncopal, sweaty, all those things can kind of help form your history as well. Another component of the history, I don't know if y'all have seen ample in trauma, it's ample T for the T thrown on for tetanus, but getting an idea of their allergies, right? We don't want to give them medications they're allergic to. Figuring out what medications they're already on, their past medical, past surgical history, family history can go into that too, their last meal, and then the last meal more so for surgical purposes, then events preceding the illness or the injury, and that can be remembered easily as AMPLE. So now that we talked about the components, and if at any point you all have any questions, please stop me. We can definitely do questions throughout the presentation, or we can do them at the end too. But physical exam wise, this is really very important component of your evaluation and can definitely help clue you into what you might be facing. So just by looking at the abdomen, right, you might be able to see a mass, you might be able to see hernia, any rashes. You could see bruising, you could see old surgical scars that could clue you in to what you're seeing, right? So does anybody know what we're seeing right here? About this one. You know what surgical scar? I wouldn't expect y'all to necessarily, but so this, if you kind of think about it as a Mercedes-Benz scar, right? You can kind of see the makeup. So if you see that, there's a good chance they've had a liver transplant or some big abdominal surgery in that region. So that could clue you in that this is a liver transplant patient just by looking at them. Or they might call you for abdominal pain and you see this rash on only one side of their abdomen. Does anybody know what that might be?
Shingles.
Exactly. So I don't know if any of y'all had this, but that can be very painful. And they might have abdominal pain, but the rash isn't formed yet. So they might just have pain of the skin in that region. So that could be something that's extra abdominal that's causing them to present with abdominal pain. So just by looking at them, looking at the patient before you even touch them, before you even done anything else, you can get so much information about what could be going on. So the next step is auscultation. This is probably the one with percussion. These are probably the two that we do the least. That's both y'all and me. But just by listening to the patient, you can listen to their bowel sounds, right? Are they normal? Are they hyperactive? Like you might, if you've ever heard of morphorrhea, that's the word that describes the hyperactive bowel sounds that could be associated with an obstruction. Are they hypoactive, right? Does the patient potentially have an ileus? Things aren't moving as appropriately through the GI tract. You could also potentially hear bruits. So if you hear renal bruits, right, that could just be a sign of renal artery stenosis or issues with the renal arteries. You could hear an aortic bruit, which could be point you to the direction of a aortic aneurysm. Percussion wise, you can palpate, you can identify. Yes.
Could you explain the bruit?
Yeah. So I don't know if y'all ever heard one. If you ever probably not. But I saw Ferg's reaction back there. But kind of like if you were like have like a carotid artery stenosis, or if you had like it's kind of like a whooshing, like a I don't have a great
The dialysis shunt.
perfect.
If you
Yeah.
kind of give a listen to that it kind of what it sounds like. It's not going to be quite as loud as that, but that's the whooshing sound
Yeah.
that he's talking.
It's kind of like a whooshing sound. That's a great example. If you listen to someone that's like fistula or dialysis graft, that's probably what you said when you be a little bit stronger, but that'd be a similar appearance sound. So those things can clue you in. And then to percussion, you can, yes.
Where specifically are you listening?
So the for the aortic bruit, so if you are on your belly button, right? If you go a little bit above, like right above that kind of midline, maybe a tiny bit to the left, that's where you most likely hear an aortic bruit. If there was a aneurysm, that's usually where an aortic aneurysm would most likely be, is after the renal arteries and before it splits into the iliacs to go to the legs. And then for the renal arteries, if you just go 2 or 3 centimeters above the umbilicus and laterally each direction, so right into the left, that's where you listen for renal artery bruit, because the renal arteries are going to have aorta come down here and the renal arteries are going to come off to both kidneys right here. So those are the locations that you would hear those. That's a great question.
But it's going to be bad no matter where you're.
Yeah. So in your standard Alabama patient might be a little limiting too. As Berg likes to say, there are 1 or even 2 or 3 Alabama units.
So don't say that.
He doesn't say that, sorry. Especially in patients who are more obese, have more cushioning between those vessels, and your stethoscope might be more difficult to hear those.
I think you did it.
Percussion can clue you into, is there organomegaly, right? Meaning, is one of the organs enlarged? Is the liver enlarged? Is the spleen enlarged? You'll have more firmness with percussion lower down than you would expect. Shifting dullness, basically meaning that there's presence of ascites and a cirrhotic. You can feel with percussion. I don't have it up here, but if somebody has a bowel obstruction, there's a bunch of gas in the bowels that can be more tympanitic with percussion. And then when you percuss the costovertebral angles bilaterally up on the back, that can be, if there's tenderness there, that can be indication of kidney pathology, whether that is pyelonephritis and ascending kidney infection, whether there's hydronephrosis, meaning that there's backup of urine into the kidneys. That can clue you in there too. And then what we most commonly do is palpation, right? So this can help you figure out, is there abdominal pain localized? Is it kind of all over? Where does it hurt the most? You can notice guarding, which is contraction of the abdominal musculature, and whether that might be voluntary, them doing it on their own, or involuntary. You can assess for rigidity, rebound tenderness, which is where you palpate and then you hold for a few seconds and you let go. If they have pain when you're letting go, that can indicate peritoneal irritation or peritonitis, which is that outside lining of the abdomen that can be inflamed when you have things like perforation, intra-abdominal fluid bleeding. You can again feel for masses, hernias, organomegaly, and then you can also, this is where I want to talk about acute abdomen. So an acute abdomen is what in surgical abdomen until proven otherwise, right? These are going to be your patients who are, their abdomen is rigid. They're going to be very firm, diffusely tender, potentially more tender in one area, but diffusely tender. These are going to be patients that are laying very still, right? If you just walk up to them and like bump the bed like this, or if they cough or anything that irritates the lining of the abdomen, is going to be excruciatingly painful for them. These are patients you worry about that there's a severe surgical process going on, whether that be intra-abdominal bleeding, whether that be a perforation of some sort, perforated appendicitis, peptic ulcer, diverticulitis. These are the patients you're concerned might need surgery. And then we've kind of just discussed this a little bit, but patients, the elderly, don't play by the rules, right? So these patients could very easily have a surgical process going on in their abdomen. You could pop in and they feel fine. They just say it hurts. The mortality has been described as high as like in the 10 to low teens percent wise. What you think about it is more than the mortality from a heart attack. More than half of these patients are going to require admission. There's different percentages in the literature, but 20% to a third of these patients might require immediate surgery. Elderly patients are more likely to have underlying conditions, right? By a certain age, you're very likely to have the presence of gallstones that are just waiting to cause cholecystitis. The older you get, the more likely you are to have had prior abdominal surgeries that increase your risk for bowel obstruction. Older smokers are more likely to start forming an aneurysm of their aorta. By the time you reach 65 or 70, most people are going to start having diverticula that can get inflamed. So just a lot of different things that are kind of already there, ticking time bombs that are just waiting to happen. Let me talk about physical exam, vital signs, lab work can be unreliable. Vital signs, these patients might be on medications that could blunt their cardiovascular response. So we talked about beta blockers, for example, so they could be in shock and might not even be close to tachycardic. Labs can be very unreliable as well. A lot of elderly patients with acute abdomens might not even have an elevated white blood cell count. I think I was reading earlier that like 13% of patients with acute cholecystitis might not even have abnormal LFTs or biliary labs. And then also history can be difficult to obtain, right? As you get older, they might not have as much a firm grasp of what's going on. Dementia could be playing a role too. The person who cares for them at home might not be present at the hospital. They just came by ambulance or might not even be home. So there can be a lot of roadblocks. So these are patients to take seriously and just understand that what you're seeing might not be everything that's going on. So any questions about all that before we kind of get into some scenarios? No? All right. So first scenario. So we have a 66-year-old female with a past medical history of prior cholecystectomy, so gallbladder removed, 2 prior C-sections, prior hysterectomy, and an abdominal ventral hernia repair. Calls EMS for 3 days of worsening, severe, generalized abdominal pain. There's associated abdominal distension, nausea, and vomiting. You show up, you get vital signs. They are right here. So heart rate 79, respiratory rate 18, blood pressure 143 over 92, O2 98%, and afebrile. And then here's your physical exam, right? So this thing we all talked about. So there's diffuse abdominal tenderness on palpation. You do notice the abdomen is distended. You hear high-pitched vowel sounds, and you see the presence of several well-healed abdominal surgical scars. So anybody want to take a guess at what this might be?
Last time she pooped.
Yeah.
I would say it's blockage due to adhesions
Yeah.
from multiple surgeries.
Perfect. So yes, this is most likely a small bowel obstruction. The pooping, I'm glad you said that. The pooping can be, can kind of throw you off, right? Because these patients could have some sort of post-obstructive, they could have some, initially some diarrhea. When you have obstruction of the bowels, you start to work a little bit heavier and faster. It's why you hear the high-pitched vowel sounds. So everything that's distal to the obstruction, you might actually have stools for a little bit while that clears out. And then by the time that clears out, then nothing is getting past the obstruction, but you're emptying whatever was distal to it. So here's some pictures of this. This is an X-ray. This is a CAT scan. So on the X-ray, you're going to see multiple. Ooh, it's touchscreen too. All right. There we go. Know that.
Sorry, I set you up for failure.
All right. So you see multiple air fluid levels all throughout, right? So that's just indicating that things are not moving. You also can see, this picture doesn't show it as well, but you can see distension of the small bowel. It'll look like kind of like coins stacked on top of each other. You can kind of get that up here a little bit. And then here on the CAT scan, once again, you're kind of seeing the same thing that's over here, but you're seeing there's a small bowel here. You're seeing small bowel should not be this thick, right? It's fluid filled. There's an air fluid level here. Small bowel should really not be anything like over like 3 centimeters, and that's a lot more than that. And X-rays can clue you in. They're still going to miss a lot of small bowel obstructions. CAT scan is going to be the way to go in the emergency department as far as ultimate diagnostics of this.
Use of ultrasound in pre-hospital care.
Yeah,
Thoughts?
I might tag in Ferg for this, but if you did use ultrasound, what you would see is you would see dilation of the small bowel, and you can measure it there, and you can measure is it bigger than 3 centimeters. You'd also kind of see kind of like it's like a kind of a whirlwind. You basically see the gastric contents not really going forward, not really going backward, just kind of swirling around, which is that peristalsis, but it just has nowhere to go. So those are things you could identify there. I'll let Ferg talk about utility of that.
Yeah, I think it'd be kind of hard pressed. I mean, that's going to be a complicated ultrasound to review. And they're going to end up having to do a CT scan anyway. So I think for ultrasound use in the field for abdominal emergencies, we're talking fast for blood trauma as a free fluid, making a decision versus flying or ground or which hospital you go to. You can see some other things like cholecystitis, but I think for small bowel obstruction, I could not use the ultrasound for that. Maybe some of the other docs could, but I probably could not. I think it's probably low utility in pre-hospital.
And that's probably not something I'm doing. That's probably not something I'm doing myself in the emergency department unless I have time or there's like ultrasound rotation medical students going through. Just because if I call the surgeon and say, hey, I think there's a small bowel obstruction ultrasound, they'll probably laugh at me and say, call me when you have the CT. So risk factors, age, like we talked about, prior abdominal surgeries. Most common cause, like you said perfectly, adhesions are going to be your number one cause. Intra-abdominal hernias, malignancies, IBD like Crohn's, ulcerative colitis.
Could you explain adhesions?
Yeah, so especially the more and more you get into the abdomen, surgery-wise, the more and more fibrous adhesions are going to kind of form between things that shouldn't, right? Because as the abdomen heals from surgery, so a lot of times that can happen is it can cause bowel to twist, bowel to stay fixed, and that can cause obstruction. So the more and more in this vignette, I gave you all a lot of prior abdominal history surgeries to kind of clue into that. And you'll see this in real life as patients. You can see on their belt, you can see all different scars from the surgeries they've had. And more just increases your risk from the more you have surgery, the more adhesions you'll form. Less likely things like stool impaction, foreign body can cause that too. Complications can lead to bowel ischemia, right? So if it is the bowel's twisting, the bowel's becoming severely dilated, that can cut off blood supply, can lead to perforation, causing peritonitis. You can get translocation of bacteria into the bloodstream. and can lead to even death if it's not treated appropriately. So big treatment that we're going to do in the emergency department, and several of these that apply to y'all. Definitely got to get antibiotics on board, fluid resuscitation, treating their pain. Most of the time, we're still going to put an NG tube in these patients to help decompress proximally. And some people are kind of slowing down on doing that, but most of the time, surgeons want it just so that way, comfort-wise, and you can kind of decompress proximally. And then getting the surgeons involved early on these patients is going to be very, very important. A lot of patients, if they've already kind of progressed, will be candidates for surgery. A lot of times they'll want to see how they go, especially if it's a partial obstruction. Might want to manage this non-operatively first. So scenario 2, I'm going to speed through a little bit because I think I'm running out of time a little bit. But 16-year-old male, no pertinent past medical history, 2 days of vague periumbilical abdominal pain that acutely worsened and is now in the right lower quadrant, associated nausea, vomiting, decreased appetite. Here are your vital signs showing tachycardia and fever. And here is your physical exam. There we go. All right, let's speed it out a little bit. So that's acute appendicitis. I had to put that one up here. Very common, 300,000 hospital appointments. Most commonly between 5 and 45 in terms of age. I think the median was 28. But it can definitely occur in elderly patients. It might be more severe in elderly patients because it can be not immediately diagnosed because it's not as common. A lot of times we don't even know why this happens, but most likely it's thought that either you get a stone, something's blocking the appendix, right? So you get a stone called an appendicolith. You have hypertrophied lymphatic tissue that's present. You can also have a tumor like an adenocarcinoma. Ideally not, but you can have parasites that cause this as well. Can lead to rupture, abscess, peritonitis, sepsis, all the bad things. And then treatment's going to be fluid resuscitation, pain control, antibiotics, and getting surgery on board a lot. You're going to hear a lot of the same things for all those. All right. Things that you might have heard of as far as physical exam. So McBurney's point, if you look at your belly button, you look at the anterior superior iliac spine, this prominence right here on your hip. If you go 2/3 of the way from the belly button to the ACIS, that's going to be your McBurney's point, which is where you're supposed to be most tender with appendicitis. There's also Rothstein's sign, which is where if you're palpating in the left lower quadrant, it will actually cause discomfort in the right lower quadrant. Psoas and obturator sign are much more rare to see. But basically, psoas sign, hip extension, or resisted hip flexion is going to cause the psoas contraction to irritate the appendix. And then obturator sign, basically, if you flex the knee and then internally rotate at the hip, and the obturator muscle can irritate the already inflamed appendix. So scenario 3, 84-year-old male, history of hypertension, diabetes, heart disease, atrial fibrillation on a blood thinner, Eliquis, and heavy tobacco use, sudden onset of severe periumbilical abdominal pain, radiating to the back, associated dizziness and nausea. Vitals are here. And then on the exam, male, severe discomfort, diffuse abdominal pain, and then kind of gave it away for you right there on the last one. You are already all thinking that this is a AAA until proven otherwise. This is what happens, right? So you have this dilation, aneurysmal dilation of the aorta, most commonly between the renal arteries here and the bifurcation where it goes down to the legs. They can rupture forward into the abdominal cavity. These patients are much more likely to expire very quickly because there's just so much room in the abdomen for that blood to go. It can also rupture posteriorly into the retroperitoneal space, the RP space, and those patients might make it longer and have time to present to the hospital for repair. Yes.
So, correct me if I'm wrong, but I believe there's actually a lot more people with known aneurysms that haven't ruptured walking around
Yes.
than we would think.
Yeah, especially in Alabama where smoking is very common. There's a lot of times rupture can be the first presentation of an aneurysm. Probably like almost up to half of them are the first time anybody ever knew. Because a lot of people just don't go to the doctor, and this might be the first time that something bad happens to make them come in. But you're very correct that a lot of patients have aneurysms that are being observed by vascular surgeons, and we'll kind of talk about in a second like how big they can get and when they're being applied.
Is it typical that they would just bust, or will they have a small area and then they start to get worse over time? Will they have that ripping, tearing pain in their abdomen?
Say that one more time, sorry.
Is it common that when they have a AAA, they bust all at once, or they start to leave, they have like a problem and then they get that ripping, tearing abdominal pain?
Yeah, so the classic presentation will be the ripping, tearing, abdominal pain from a very significant rupture, right? You can't have things like contained leaks where it can, like a very small area can rupture and the body can actually contain it, which might happen before the big one happens. And we might not even know about that, or might just happen to find it if they come in for a pain associated with that. But when it happens like this, that's what we're concerned about, because this can kill somebody in just hours if it's not discovered immediately. This is a CAT scan right here. You can see all the white right here is this is all active bleeding. You can see how
Touch that again.
I did. You can see how big the aorta is here. That is not supposed to be that big. So usually anything over 3 centimeters is going to be abnormal for the aorta. Usually when it gets in like the 5.5 range is when it is repaired. If you have, I forget the exact details, but if it grows too fast and too short of a time frame, even if it doesn't hit 5, that could be a reason for it to get repaired as well. So risk factors, tobacco use is in bold. I think like 90% of people with ruptured AAAs have history of tobacco use. It is very high. Way more common in males. As you get older, hypertension. Actually, if you have a first-degree relative with a history of a AAA, you're more likely to have one as well. So you can thank your parents for that.
I gotta get a scan.
So this is your risk of rupture in the first year, if depending on size, right? So it's still pretty high, but lower until you get about 6.5, and then it really gets up. There's 20% chance it'll rupture in a year, and then if it's greater than 7, there's a 33% chance, so 1 in 3 chance that it'll rupture within a year. That's why they repair them in order to get to that point. So you're greater than 50% had no idea that they even had this to start with. So the classic triad is hypotension, flank and back pain, and a false abdominal mass. You might see this in 1/4 to half of the patients that come in with this. So this is not, it's not always going to be easy. And then size and location, kind of we're talking about the direction it ruptures into can play a role in mortality, and also how big the hole is can play a role into that as well. So clinically can kind of point you in that direction. If someone's crashing, you can definitely see this with ultrasound. And then if they're stable enough to make it to the CAT scanner, then that's what we would look at. Treatment, blood. These are patients that very well might require massive transfusion protocol, emergent vascular surgery consultation, and then emergent surgical repair. Berg, how much more time do I have?
We're good. Keep going.
Keep going. All right, you cut me off though. You need to.
Yes, sir.
All right. So got a few more scenarios. So this is a 24-year-old female history of endometriosis, having 2 or 3 days of left-sided pelvic pain that just recently acutely worsened, and she almost passed out. She's had mild vaginal bleeding and associated nausea and vomiting. Her most recent menstrual cycle was 6 weeks ago, and after missing her most recent cycle, she did take a home pregnancy test that was positive 5 days ago. There we go. All right, so here's your vitals. This patient just had a ruptured ectopic, right? So your vitals are suggesting they're teetering on the edge of hemorrhagic shock. And then here's your exam. So pale, abdominal rigidity, guarding. So this is starting to present as an acute abdomen from hemorrhagic ruptured ectopic pregnancy. I love that y'all caught that right away. That's great. So here is an ultrasound where you actually see this ectopic pregnancy. So this is the uterus. Should be intrauterine pregnancy. It is not. Here's your bladder. And then this doesn't have it, but if this had ruptured, you would see like associated free fluid, especially in that patient that we had, if they're bleeding that much. So 90+% of these are going to implant somewhere in the fallopian tube, whether it's the ampulla, the isthmus, the infundibulum, but they actually can present, they can just implant anywhere in the abdomen, on the peritoneum. They can actually present, they can implant in the cervix. So there's a lot of different places that these things can go. So they might not all present the same way, right? So this happens in 1 to 2% of all pregnancies. We talked about those are the locations. So prior ectopic pregnancy increases your risk of another one. They're 10 times more likely. So this is a big risk factor. Any prior surgery or irritation of the fallopian tubes, whether that's due to endometriosis, prior removal of an ectopic pregnancy, ascending infection, anything like that that makes the fallopian tubes more abnormal and more places get caught on can make this more likely to happen. And then the older you get, smoking and then assisted reproductive technology like IVF can make you at a higher risk of this as well. You can actually get something called a heterotypic pregnancy. So that means you have a normal intrauterine pregnancy and an ectopic at the same time. So this can be really tricky. You usually see this in patients getting IVF, but it's possible to have an IUP, meaning intrauterine pregnancy, and an ectopic at the same time. But just because you see something in the, you see what looks like a normal pregnancy in the uterus doesn't always mean there isn't an ectopic concomitantly. Usually ultrasound is going to be our way to diagnose this. And then treatment is about the same, resuscitation, pain control, getting the OB-GYN colleagues on board very quickly. Depending on where you are, this can be treated medically, this can be treated surgically. If you've already ruptured, it's going to be surgery every time. But if you're, the earlier on you are, the more likely medical therapy is going to work. So it's very reasonable they might want to try like methotrexate or similar medication first for surgery. Yes, sir.
If we're in ectopic pregnancy, are we expecting, and it's ruptured, are we expecting a lot of bleeding?
So you could have a little bit of bleeding, but you certainly can't have a lot of bleeding. So there's a spectrum to it. You could have hemorrhagic shock from the ruptured ectopic. You could have minimal bleeding from an ectopic. That's
Yeah.
ruptured.
Yeah, a lot of that bleeding are the internal, right? So you're not gonna see that.
Yeah.
So more or less, what I'm thinking, like, so we're treating them as a trauma patient if they start desat, right? Almost from blood loss.
Right, right. So they get
Exactly.
resuscitation, they have, blood clots, they get blood clots, they get TXA.
Would we stick with the permissive hypotension at that point, kind of keep going when bloody clots out, or we just kind of send it, and if we don't have blood here. So
Right, right. So I think they're gonna get a liter at least of fluid, see if it gets better. If it
Okay.
gets some better, great. It probably won't. At that point, you're gonna back it off TXA and recognize this and get them to the hospital.
That's what I was gonna
So
ask.
we are going
Yeah,
to
Yeah, that's
Yeah,
very
TXA should be up on this too. That's definitely a great
Yeah,
intervention.
and when you get to the hospital, when you get there, you find a physician, say, hey, this patient has an ectopic, right? And that gets things moving. You don't say, I got a 24-year-old with abdominal pain who's hypotensive. You say, hey, I got a 24-year-old with ectopic who's in shock. That's when we move fast, right?
Yep.
The tricky part is that most of the cases, you're not gonna have somebody who's had a positive on pregnancy test like this scenario. So the truth is it's gonna be very difficult to differentiate that pre-hospital setting, which means, in my opinion, we have to err on the side of patient caution. And any female of childbearing years with acute abdominal pain, we have to assume is an ectopic until it's proven otherwise.
Yeah.
Which means that makes operational changes, right? That might not be one that you take it easy and drive with traffic. And you need to go ahead and make sure you have good vascular access and get them on to the care.
So you're gonna see a lot of patients with abdominal pain. And the key things you talk about here, you're gonna have to assess that patient and recognize if they're sick or not sick. Use all your tools, right? Vital signs, mental status, physical exam, and your perceived history. So 24-year-old, childbearing age, abdominal pain, that's tender, that's tacky and hypotensive. The first thing you should think of is ectopic pregnancy. Probably not ruptured aneurysm, right? 60-year-old dude that smells like Camel ultralights, right? Abdominal pain, hypotensive, tender belly, tachycardic, you would be thinking aneurysm. Does that make sense?
Okay. So a few more to knock out. 8-year-old female, dementia, hypertension, diabetes, prior heart attack with PCI, which is percutaneous coronary intervention, fancy word for stent, end stage heart failure, and AFib for acute onset of severe abdominal pain that happened 3 hours ago. And also notes on your further history, several months of postprandial pain and occasional bloody stools. Here are your vitals, fairly unremarkable. And then here is your exam. There's chronically ill, soft abdomen, minimal diffuse tenderness. Anybody want to take a stab at this one?
Cholecystitis.
So this one's kind of a little hard. So this is actually acute mesenteric ischemia. And what is this? This patient has poop, right? Pain out of proportion, which we'll get to.
That's good.
Yeah, I appreciate at least one person appreciated that. No, but it's a good way to think of it, right? Pain out of proportion. An elderly patient with a ton of comorbidities. Mesenteric ischemia is something that you cannot miss. So what you're seeing here is basically where you're having acute, it can be acute and chronic. We'll talk about that in a second. But you're getting an acute blockage of blood supply or sometimes venous drainage from the bowel, right? So bowel is not supposed to be black and dilated like that. That's dead bowel. That's going to get taken out. So on these two pictures right here, you can kind of see, here's the aorta coming down. Here's the aorta coming down. This is the superior mesenteric artery, which is the most common culprit where this arrow is going right here. And you can see it just abruptly stops, right? So there's an acute blockage right there, whether it be embolic, like something traveled there, or whether it be thrombosis, there's already plaque that ruptured there. That's, you can see here in the distal reconstitution, so there's some blood flow, but that's what you'll see on imaging is an acute blockage of the blood supply to the intestines. This can be very, very life-threatening. So mortality as high as 50 to 80%, depending on who you ask. 95% of the time is going to be acute. There are some patients where you have kind of chronic blockages, kind of like think about it like angina of the bowel. So the same thing that's going on in the heart when you think of angina, there's blockages. When you eat, you need more blood supply to the heart. Same things like or to the bowel. Same thing when you are dirtying yourself, the heart requires more blood supply. That's when you're looking symptoms for chronic. Most commonly involving the SMA. So arterial embolism, these are sources of blockages that come from other places. This patient had atrial fibrillation, was not on a blood thinner given their age, so they're more likely to form clots in the heart. If you have end-stage heart failure, you might have thrombi that form in the heart that can travel upwards, cause stroke, downwards, and cause mesenteric ischemia. You can also have thrombosis, which is just rupture of underlying plaque that already exists, atherosclerosis. 20% or so can be non-occlusive. These are usually your patients that are already sick in the hospital on a bunch of pressors, already causing decreased blood supply to the bowel, but there's no like definitive blockage. You won't really as commonly see patients like this that you're bringing into the hospital. Classic finding we talked about is pain out of proportion or poop. This one you're going to want to get a CT angiography. Basically, contrasted CT where the timing is such that the dye is in the arteries when you take the pictures. Treatment, fluid resuscitation, correction of electrolyte abnormalities, trying to avoid pressors if possible, because that's already going to decrease, squeeze those vessels supplying the bowel. So you're trying to avoid those if possible. Treating for pain, which might be very difficult to do. Definitely getting antibiotics on board quickly because this bowel can die, can become infected very quickly. And then you're going to get general surgeons and vascular surgeons. This patient's going to go to the ICU.
Yeah, well, just hold off the last two scenarios if we can.
Okay.
Take a quick break. For folks online, and then we'll come back in about 5-10 minutes.
Yeah, we'll take about 5-10 minutes, and everybody stay tuned online. We'll be back with Dr. Brown, another lecture. If you're online, please remember to fill out an form. There's a link in the chat. If you don't have access to the chat, you can send an email to Alabama EMS challenge@gmail.com. You get an automated reply with a link. For the attendance form, the password for the attendance form today is Trussville, all lowercase. Those case sensitive. Trussville.
Any questions, put in the chat box. We'll come back to those.
Yeah.
Thank you, sir. Good job.
Yeah, stay tuned. We'll be back about 5 or 10. Got Dr. Julie Brown going to give us a lecture.
All right, let's get started, y'all. There are some things in this lecture that were in the last lecture, so there will be some repeating, but I'll try to go through it fast. All right, so these are the things we're going to talk about. We're going to start by talking about some emergencies of pregnancy, things like miscarriages, ectopic pregnancies, placental abruption, placental previa, and then the hypertensive problems, preeclampsia, eclampsia, things that you might see in the field. And then we'll talk about imminent delivery. So if a patient is going to deliver in the field, you need to know how to deliver a baby, right? Most of the time they deliver themselves, but sometimes they don't. And then we'll talk about some of the complications of childbirth. All right, so typically you hear about pregnancy being divided into 3 13-week trimesters, so first, second, and third. But really, let's think about it in about 2 20-week halves. So kind of early pregnancy, late pregnancy. So early pregnancy, the baby's not viable, meaning if something were to happen, that baby is likely not to make it, okay? So that's early pregnancy. And then late pregnancy is we're gonna do everything we can to save baby and mom, okay? All right, so whenever you have a pregnant patient, you gotta call out for, any pregnant patient, things that we wanna know. We wanna know how far along they are. So are they 2 weeks? Are they 6 weeks? Are they 38 weeks? Because that makes a big difference. If they don't, there's some calculators you can do online of how far along they think they are based on their last menstrual period. You want to know how many previous pregnancies they've had. If they're 38 weeks pregnant and they've had 4 vaginal deliveries already, chances are they may be in labor already. We want to know how many other deliveries and the types of deliveries they've had. Have they had multiple C-sections with all of their pregnancies? They probably need another C-section. Was there any trauma involved? So did the patient fall? Were they in the car accident? We want to know if they're having contractions. Has their membranes ruptured? So do they get that gush of fluid? Did their water break? Are they bleeding at all? And if they ever had any complications from a previous pregnancy, so things like diabetes, have they had preeclampsia, or have they ever had preterm labor? If anybody has any questions anytime in the lecture, please just stop me. All right, so let's talk about some of the complications of pregnancy. So miscarriage is going to be that most common complication of early pregnancy. It complicates about 15 to 20% of pregnancies, and about 80% of those occur before the 12th week of pregnancy. So most of the time miscarriages occur early. And symptoms that you think of is a patient that has back pain, maybe they've had nausea and vomiting all of their pregnancy and now they don't anymore. Have they passed any tissue? Are they spotting? Are they having any bleeding? Or are they passing kind of clots that are more than just like a normal cycle? So the treatment for miscarriage, are they stable? We don't want to focus on kind of providing support to the family and to the patient because that's rough, especially if they were excited about the pregnancy. But also these patients can have signs of hemorrhagic shock. So with these patients, we want to make sure we get an IV. We want to start resuscitating them with IV fluids. You can give TXA. And if they passed any tissue, try to transport that with you to the hospital. So put it in, any kind of container that you have or like a green bag. Because they may want to send it off to see why they miscarried, would be the purpose. So we'll talk a little bit about ectopics. I know we talked about it in the first lecture, but ectopic is implantation of a fertilized ovum outside of the endometrial cavity. So it complicates 1 to 2% of pregnancies. And it's the leading cause of first trimester pregnancy-related deaths. And that's usually from hemorrhage. Maybe it's from infection. A patient didn't know they had an ectopic. And then that retained product had just been sitting there for a week. They can get septic from that. Or if they have to go to the OR, they can have anesthesia complications. So we talked about this. The majority of ectopics are in the fallopian tube, but some can occur in the abdomen, in the cervix, or in different parts of the uterus, like the uterine wall. It is always surprising whenever you have a trauma patient who's pregnant and you find the baby in the abdomen. That's not normal, right? So signs of a ectopic pregnancy, that sudden severe abdominal pelvic pain, patient that's dizzy or fainting, probably think that they have blood loss. If they have kind of pain in their shoulders, that's that referred pain from their peritoneum being irritated by blood, or pain in the lower back. So how do we manage these? We have to make sure that we have a high index of suspicion, like we talked about earlier, a female of childbearing age who's complaining of any abdominal pain, have a high suspicion for an ectopic until we prove that it's not. And then if they're having signs of hemorrhagic shock, then we want to treat that. So this is what we were talking about earlier. So this is an ultrasound. So this is the liver. So this is the right upper quadrant. So this is your liver, and then this is your kidney over here. And this black, you see this kind of black fluid here, that's blood. So that would be a ruptured ectopic with blood in the abdomen. And then here, this is your uterus, and then this is your fallopian tube, and this is the ectopic right here in the tube. All right, so what about placental abruption? So that is premature separation of the placenta from the uterine wall. It complicates about 1% of pregnancies and 30% of bleeding during late pregnancy. But it's really associated with a pretty significant perinatal mortality and morbidity. So essentially, if you see here, there's two different ways that it can happen. So the placenta can be attached kind of lower in the uterus, and then if it detaches, you can get bleeding that's going to come out the cervix, which may have vaginal bleeding. Or if the placenta is up high in like a normal pregnancy, you may not actually get vaginal bleeding because this blood is here at the top of the uterus. And so it's not going to get down to the cervix. Most of the time, and I think that's this slide too. If you have a history of trauma, you want to think in a pregnant patient that has abdominal pain, you want to think that it could be a placental abruption until we prove that it's not. So we suspect this in a pregnant patient that has vaginal bleeding or abdominal pain, especially if they have a history of trauma. But it can actually manifest up to 5 days after the initial trauma. So the patient could have like had a minor fall 5 days ago, and now she's like, oh, like I'm really hurting right now, or now I'm having vaginal bleeding. Think it could be placental abruption. You're not going to be able to diagnose this pre-hospital. I'm not going to be able to diagnose it with looking at them. We really need an ultrasound for this. And placental abruption can cause preterm labor. So what are we looking for on exam? So we're looking for a tender hypotonic uterus. So the uterus is not going to feel as firm as it does in like a normal pregnancy. It's because that placenta is no longer attached to the uterine wall. And these patients might have high frequency but low amplitude contractions. How we manage these, so it's the same as all the pregnant patients that we talked about. We want to get IV access, monitor for signs of shock, and then transport these patients to an appropriate definitive care, right? So if you're worried about this patient, if they're like hemorrhaging out in front of you and you don't have access to blood, and a freestanding ER is 2 minutes down the road versus 45 minutes down the road, maybe stop there and get some blood. But otherwise, you're going to want to go to a hospital that has OB because this patient probably needs to go to the OR. And that's not something an ER doctor can do. And then placenta previa is where the placenta overlies the internal os of the cervix. So if you see in this picture, so this is the top of the uterus, so the kind of top of the abdomen, and this is the cervix, is kind of the lower right next to the vagina, and the placenta is overlying it. And so it can cause bleeding during late pregnancy. Occurs about 0.5% of pregnancies. And the reason we worry about this is because it can cause painless bleeding in late pregnancy versus placental abruption is that painful bleeding, and placenta previa is painless. The reason we want to know about this is a lot of times we check patients to see how far their cervix is open. A digital, like an internal exam is contraindicated in a patient that has placental previa because that placenta is right there. And if we do a digital exam to check their cervix for how far they're dilated, we could hit that placenta and then they could hemorrhage out, which could be really bad, right?
If they've been getting prenatal care.
You would think that they would know. You would think that they would know. And a lot of times patients can have placenta previa and the placenta will move during the pregnancy. So a lot of times they'll just keep checking them to see if it's moved. Because if they end up having it right before delivery, then they'll end up doing a C-section. So most of the time people know, but you can't count on that. All right, management, again, IV access and transport the patient, and then resuscitate them if they have signs of shock. And then hypertension during pregnancy. So there's really 3 types of hypertension that you can have during pregnancy. Well, really 4. You can have hypertension before pregnancy, is just that patient who has baseline hypertension. You can have gestational hypertension, which is hypertension that occurs during pregnancy and resolves when after the patient gives birth. You can have preeclampsia, which would be gestational hypertension plus proteinuria. It is when you have protein in your urine. So it's not something you're going to find out pre-hospital, right? That's something we're going to find out in the hospital. Versus eclampsia is when a patient has signs of preeclampsia plus seizures. We'll talk about these individually. So the diagnosis of preeclampsia is going to be in that pregnant patient who has hypertension, so blood pressure greater than 140/90, and they have proteinuria, meaning protein in their urine, and they're after 20 weeks gestation. So it's before 20 weeks, it doesn't matter as much because they're not viable, meaning that if the mother were to deliver, the baby is not going to survive. This complicates about 12% of pregnancies and accounts for about 20% of maternal deaths. The signs and symptoms that you look for is that patient who is 30 weeks pregnant, their legs are swollen, their vision is blurry, they have a headache, they're having some epigastric pain. Lab-wise, they might have acute renal failure, meaning their kidneys are shutting down. They may have pulmonary edema. So the management of this is supportive care, transport these patients. And then a lot of times we'll give a MAG in the hospital to prevent them from developing eclampsia, which is the presence of new onset seizures during pregnancy or postpartum, because this can happen after delivery. The management for eclampsia is magnesium, which you carry, but the dose is 4 to 6 grams pretty quickly, which is a lot of magnesium to give somebody. This can cause some hypotension, but you got to think these patients are probably hypertensive, right? That's why they develop eclampsia. But the toxicity for magnesium, you can look for loss of deep tendon reflexes. They might have respiratory depression. So if you're giving this patient a ton of MAG, just watch for their breathing, put them on end-tidal. They may have muscular paralysis, respiratory arrest, or maternal cardiac arrest. But usually you're going to give this to the patient and you're going to get them to a hospital. So hopefully those things would happen once they get to the hospital. So if you have a pregnant patient who's calling 911, really have a high index of suspicion that they could have some of these complications, so that we can make sure that we're treating them appropriately and that we're not just dismissing them, because pregnant women can have a lot of problems. Any questions about those? Cool. All right, so now we're going to talk about delivery and the process of a normal vaginal delivery. We're not going to talk about C-sections because that's outside of your scope, that's outside of my scope. But we'll talk about what you should do if a patient is in labor and she is going to deliver right in front of you. And then we'll talk about some of the complications. All right, so we're going to start with a case. So you get called out for a 24-year-old female complaining of abdominal pain. You get there and she's laying on the floor, she's writhing around. What is your first thought? Oh crap. What are you doing? She says, I think I'm pregnant. And then you say, uh-oh, great. And then that's you. All right. So out-of-hospital deliveries are a fairly rare occurrence. They account for about 2% of all births in the U.S. The majority of them are uncomplicated vertex presentations. That means head down, like a normal vaginal delivery. And they really only need routine supportive care. Most babies deliver themselves. You just kind of help make sure they don't fall when they come out. But there are some notable exceptions that can really cause a lot of problems, and those are the problems that we want to talk about. So pre-hospital deliveries, that 2%, are usually from pretty high-risk pregnancies. It's that mother who's really premature, the baby who's really premature, and they didn't think that they were going to deliver this early. Some of the known contributors to unplanned out-of-hospital cardiac arrest are young maternal age. Maybe it's, a 16-year-old who's pregnant who didn't want to tell anybody she's pregnant and has been hiding it for the past 30 weeks. The mom who is having twins or triplets, so multiparity. Maybe they had a lack of or poor prenatal care. They knew that they were pregnant but didn't want to think that they were pregnant, tried to ignore it. Maybe they had extended travel to the hospital. Maybe they live in really rural Alabama and their closest facility is an hour and a half away, or unemployment. And all of these things contribute to the really high maternal and infant morbidity and mortality. All right, so let's talk about imminent delivery. So what is it? It's a delivery that's going to happen really soon, probably before you get to the hospital. So you might as well just deliver on scene and then go from there. Usually these happen because of like an abnormally low resistance of the birth canal, meaning the baby can come out really quickly, abnormally strong uterine contraction, so that uterus is contracting really high, strongly, and it's pushing the baby out really fast. Maybe the mom didn't know that she's having painful contractions. Maybe a patient that has a spinal cord injury who's pregnant, who has no sensation. Maybe they didn't know that they were having contractions, or a combination of all the things. The major risk factors are placental abruption, multiparity, so having more than one baby in the uterus, and then a small infant size, because if they're smaller, they can come out quicker. So what do we want to do? So we want to try to get a rapid history. That 24-year-old that says, I think I'm pregnant, we want to try to find out, have they ever been pregnant before? Have they ever had any vaginal delivery, C-sections? Have they ever had a precipitous delivery, meaning a really fast delivery? Because those patients are more likely to have a quicker delivery the second time. We want to try to figure out what their gestational age is. A lot of times if a patient didn't know they were pregnant or was trying to ignore it, didn't take a pregnancy test, they may not know. There are calculators, like I said, online that you can use. You can plug in their last menstrual period, or you can use kind of this. So if their uterus, if you can palpate their uterus at their umbilicus, they're about 22 weeks. So that's an easy way for you to remember. So if you can palpate the fundus, the top of the uterus, right above the umbilicus, that patient, the baby is probably viable because they're past 20 weeks. Does that make sense? Just an easier way for you. Is that they're lower than the umbilicus and they're going to be really early. Then we can ask like what medical problems they have. Do they have high blood pressure at baseline? Are they diabetic? And then what medicines are they on? So you're going to do, if somebody's like, I think I'm about to deliver, I'm having really strong contractions, they're every 30 seconds apart. You want to do a quick external exam just to look for the presenting part. And what I mean by that is, can you see a head or can you see a foot or a bottom? What can you see? So if the mom is voluntarily pushing with her contractions, the likelihood of her delivering soon is pretty high, because that means that cervix is probably fully dilated and the baby is ready to come. If you can see the fetus, if you can see the head, and I have some pictures of this, if you can see the head coming out or crowning, then you're going to deliver. Or if the mom says, I feel the baby coming, then that's a pretty high likelihood that you're going to deliver, because patients don't usually lie about that, right? So this is what I mean by crowning, and I have some real pictures too, is that this is the vaginal opening, is that you can actually see that head. So sometimes you'll see hair and you're like, oh crap, let's get ready. So if you have a pregnant patient and she's like, I think I'm about to deliver, you do just a quick exam and say, oh, there's a head, start getting ready. So if it's only a 2-man crew, call for backup, try to get somebody else there, because you're going to have not one patient, you're going to have 2, right? You're going to have baby and mom. Try to get a nasal cannula on the patient in the event that they decompensate, that you're ready. Try to get IV access on them, so in case you need to give them fluids or blood product to resuscitate them afterward, that you can. Yeah. All right, so back to our case. So we have the 24-year-old female. She says she thinks she's pregnant. She's writhing around on the ground. And she says, I feel like I need to push. And you're like, whoa, here we go. She says, I've had 2 previous vaginal deliveries, no medical problems, but I didn't have any prenatal care. I was trying to ignore the fact that I was pregnant. So you do an exam and you see this. So that is the head coming out. That is crowning. You better start getting ready. Go get your OB kit. We're doing this, right? You're not going to make it to the hospital. Even if you're 2 minutes away, you're not going to make it. All right, so we're going to prepare for delivery, call for help. So how do we try to deliver this baby? So you're going to try to put the mom in the lithotomy position, which is this. So essentially the mom is kind of semi-seated. Her hips are flexed and out, and then the knees are flexed. So this is the position that is going to best open up the pelvic opening, right, for us to deliver. So you're going to try to deliver the head first. If the baby is head first, we're going to deliver the head. You're just going to get your gloves on, obviously. Apply constant kind of a light pressure to the head because you're just trying to slow down the baby from coming. We don't want to push on the head and prevent it from coming. We just want to kind of gently guide it, okay? We're not going to put traction on the head because we don't want to pull the head out too fast because the shoulder's got to turn, which we'll talk about in the next slide. Just let mom kind of slowly push the baby out into your hand, okay? Most of the time, the baby's face is going to be down toward the floor, okay, or to the mom's back. All right, so after you deliver the head, usually the infant's going to turn to one side or the other so that you can rotate, or they can rotate their shoulders. So the head comes out and then they're going to turn. Once they turn, you're going to kind of guide the head kind of downward because you're going to try to get that anterior shoulder out. And then once that anterior shoulder is out, they're going to gently pull the baby up to get the posterior shoulder out. Got some pictures of that. So baby's head is out. So initially baby's head's coming out, facing downward. They rotate. And you're going to kind of gently guide down to get this anterior shoulder out. And then you're going to gently guide up to get that posterior shoulder out. And once you do that, usually the kind of torso and the legs immediately follow. Just really hold on to the baby because they're really slippery. And if you're not like on the ground, if they're on your stretcher, you don't want the baby to fall, right? They're really slippery. And then you can cut the umbilical cord, usually kind of wait about 30 to 60 seconds after delivery to cut the cord to transition the baby and increases infant iron stores. Usually mom can lose about 500 cc's of blood, which seems like a lot, especially in the field, but that's normal for a delivery. So this is that same thing. So these are all kind of the things that hopefully are happening before you get there. The baby starts crowning, is face down. They rotate, turn their head, deliver that anterior shoulder, pulling down and then pulling up for that posterior shoulder. And then the placenta usually is going to deliver about 10 to 30 minutes after the baby. But don't delay transport. You don't have to sit there and wait for it. They can deliver the placenta in the hospital. But to help when that placenta does deliver, you can externally massage the uterus. So just on their abdomen below the umbilicus, try to externally massage it to help the placenta let go of the uterus so that it can come out. You don't want to, if the uterus does start coming with the cord, you don't want to pull a lot of traction on the umbilical cord because you think the umbilical cord is connected to the placenta. You don't want to pull too much traction on this because it can tear and then the placenta is stuck. And then they probably have to go to the operating room to get it out. All right, so back to our case. So this 24-year-old who's pregnant, she feels like she needs to push and she's crowning. So we started getting ready for delivery. We put her in the lithotomy position, so that kind of semi-seated, hips and knees flexed and hips abducted, so out. You deliver that head, and then you try to gently guide down to deliver that anterior shoulder, but the head goes back into the perineum. You're like, oh crap, what do I do now? So that's one of the complications of childbirth that we'll talk about in a second, that's shoulder dystocia. So breech presentation is when the head is not down. It's when the foot or the butt is down at the cervix. It complicates about 3 to 4% of all deliveries and about 2.5% in the pre-hospital setting. There's a couple different types of breech presentation. So it can just be butt down, it can be feet and butt, or it can just be like one leg or two legs. The complications from breech presentation, the problem with breech is that there's not enough of the baby's like tissue to fully dilate the cervix. Because you got to think usually the head is pretty big on the cervix to help fully dilate it. And if you just have a foot, it's not going to get fully dilated. So that is one of the problems. The head, if you are able to deliver the baby with a breech, the head can get entrapped. You can get prolapse cord, which we'll talk about, or injury due to excessive traction because you're just trying to get the baby out. Once you realize that there's a breech presentation, you want to try to get this patient to the hospital as quick as you can because usually these deliveries are pretty difficult and usually they need a C-section. So if you see a foot, try your best not to deliver the baby, but if you have to, then you have to. If the delivery is already a process, the mom is pushing, you already see a foot, put the mom in the lithotomy position like we talked about. Try to avoid assisting with the delivery if you can until it gets to about the umbilicus of the baby. Try to let the buttocks in the trunk deliver them, or try to let the legs deliver themselves in the buttocks. And then once you kind of get to the umbilicus with the torso and the head, apply suprapubic pressure, so pressure right at the pubic bone, not at the uterine fundus, so not at the umbilicus. You're going to do it kind of lower down, and then try to deliver one shoulder at a time, and then the head. And then umbilical cord prolapse. So this is when the umbilical cord descends through the cervix and through the vaginal opening prior to the baby's presenting part being head, foot, buttocks, whatever it is. This can cause problems because whenever you try to deliver the baby, when the baby tries to come out, they're going to compress that cord. And that cord is what's providing them with all their oxygen and nutrients, right? So this is scary. This is the thing where they tell you that if you see this, that you're going to ride into the OR with them because it's a problem. So the risk factors for this would be abnormal presentation of the fetus. So the baby is breech. If it's just a foot coming down, the likelihood of that umbilical cord getting in the way is pretty high, just because there's not as much of the baby down there. If the mom had lack of prenatal care, meaning she didn't know she was breech, she didn't know she had the umbilical cord so low. It can happen with twins. So if the first baby gets delivered, a lot of times with the second baby, this can happen before they get delivered. Or if the baby's really big, which is macrosomia, it means the big baby. And this is associated with pretty increased perinatal mortality. The treatment for this is to put the mom in a knee to chest position. So you're going to try to flex those hips as much as you can, and then gently elevate the presenting part. So don't try to push the cord back in there. You're going to have to use your hand and push up on the head or push up on the foot because you're just trying to get it off of the cord. You're not trying to deliver the baby. You're just trying to push it off the cord so that the baby is getting nutrients, right? Until you can get to the hospital and they can take this person in the OR to do a C-section. Because most of the time that's what happens. And this is like the classic teaching in medical school is that if you see a cord, you have to elevate the presenting part and you ride the stretcher to the OR and you stay there until they get the baby out, which is obviously not ideal in a pre-hospital setting, but you're going to do your best. Okay, and then shoulder dystocia, which is like the case that we talked about. This is failure of the fetal shoulders to deliver following delivery of the head. So usually if it doesn't happen within 60 seconds, they probably have shoulder dystocia. Usually it's because the shoulders are stuck on the mom's pelvic bones. Most of the time it's the anterior shoulder against the pubis symphysis, but it can happen with the posterior shoulder and the sacrum. So like in this picture, usually it's this anterior shoulder on the pubic bone. Usually this is because the baby's just really big, but sometimes it can happen if baby tries to deliver too fast and they don't have an adequate amount of time to fully rotate their shoulder. Sometimes this can happen. There's really no reliable way to predict this. If a baby's really big, a lot of times OB is ready for that in the event that they have shoulder dystocia, but you're probably not going to know that, right? We're not going to know that in the ER or pre-hospital. This is heralded, so you know you have a shoulder dystocia by the turtle sign, which is what happened in that case. So essentially the head delivers and then the head goes back in because the shoulders are trying to deliver and they can't, so it just kind of gets sucked back into the opening, which is a turtle sign. It's really associated with pretty significant fetal morbidity and mortality because when you're trying to get the baby out, you can injure the brachial plexus. It can cause suffocation to the baby. But if it's relieved within a couple of minutes, the incidence of permanent injury is pretty low. So how can we treat this? So the first line would be a McRoberts maneuver, which you can do in the field, which essentially you're putting knees to chest, so hyperflexing the mom's hips, and then you're going to push on that pubic bone. Essentially what this is going to do is increase the distance between the pubic bone and the sacrum. So hyperflex the knees and then push down here to try to get that anterior shoulder out. If that doesn't work, you can put the mom on all fours, which is called the Gaskin maneuver. And if neither of these work, there are like 6 other things that you could try. But if neither of these two work in the pre-hospital setting, the likelihood of anything else working is pretty low. So you need to focus on getting the patient to the hospital, okay? And then postpartum hemorrhage is the leading cause of maternal death worldwide. So if y'all remember, I said you can expect to lose about 500 cc's of blood with a normal delivery. So postpartum hemorrhage is greater than 500 cc's. There's 2 different types. There's primary and there's secondary postpartum hemorrhage. Primary is within 24 hours of delivery. Complicates about 4 to 6% of all pregnancies. And most of the time it's due to uterine atony, which is on the next slide. Essentially the uterus does not fully contract back down after baby is delivered. And so there's a lot more room for those blood vessels to bleed. It can be due to inherited coagulopathies. Maybe the patient didn't know she had some sort of bleeding disorder. If the placenta is retained, if the mom has placenta accreta, meaning the placenta implants into the uterus in a different way and it can't come out. Sometimes the uterus can invert itself, or if there's significant pelvic or vaginal trauma. And then secondary occurs about 24 hours later to weeks, and that's usually due to retained products of conception. So there's part of the placenta that's stuck in the uterus. So this is uterine atony. So usually after you deliver baby, the uterus contracts back down. So it just gets smaller. Oh, sorry, y'all. It gets down. So this is bladder, and then this is the uterus. So it usually gets smaller. And if it doesn't, this is uterine atony, if it doesn't contract down. And essentially there's blood vessels all in here, and they can just bleed, 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 bleed. So the way you can treat that in the pre-hospital setting is doing a fundal massage. So just put your hand on mom's baby and just massage it to try to get that uterus to contract down. If there's obvious vaginal trauma, like if there's a big laceration, you could try to like put gauze and pack it. But most of the time the bleeding is going to be from this, okay? Other things you can do, if you're critical care, you can use oxytocin. If y'all can use TXA or blood to treat this. All right, so back to the case. So we had that turtle sign, which means the head went back into the perineum when you try to deliver, which is that shoulder dystocia. You apply the McRoberts maneuver, meaning hips hyperflexed, and you're applying that suprapubic pressure. And then you deliver the anterior and posterior shoulder, and then the baby comes out, and then everybody's happy. And you're like, whew, I feel good about myself, right? All right, so when we assess a pregnant patient, we're concerned for labor, make sure you do just a quick external exam. You don't have to do an internal exam. You just want to make sure that you know if that baby's coming while they're in your care. The spontaneous delivery of a neonate's usually the head, then the shoulders, and then the body and legs together, and making sure that you know the complications that can occur during childbirth and knowing how to treat those. Most of the time, that's going to be resuscitation with fluids, blood, TXA, and transport. Cool. I have some, this is my dog, Lila. Do we have more time, or do you want me to be done? I can
We
be
have a
done.
little bit of time. We did have a couple of questions that
Okay.
come in. So one was, wanting you to expand on use of, actually, all the questions are about TXA. Expand on the use of TXA for placenta abruption is it appropriate for placenta abruption?
Dr. Ferguson, placental abruption with TXA. So everything that I've learned is that you give TXA once baby is out. With placental abruption, the baby's still in. So I'd probably say hold it and just resuscitate with fluids and blood.
Yeah. And the other option with that is call med control. You're not say yes, give it.
Yeah.
So would I give it? I'm not going to answer that online. But call med control for backup on that.
Yeah, and the other one's actually back to the first lecture, also a TXA question. Would it be appropriate to nebulize TXA for esophageal varices or other facial trauma that has severe bleeding into the airway, such as a self-inflicted gunshot wound? I would say no, but,
Yeah, I think the other thing we should be doing before we do that, we should be giving, sit them up, passive O2, hemorrhage control best we can with packing, volume resuscitation. If you're way far out and you get to that, call med control. That'd be a call and do. But I haven't been my neb, DXA,
Yeah.
for some nosebleeds, a few other things.
So getting to like a variceal bleed is pretty low.
Yeah.
yeah, I think really the problem with the esophageal variceal bleed would be that it hasn't clotted at all, right?
Right.
And TXA is gonna only help after clots start to form, correct?
Yeah.
Because it's gonna slow down the mechanism for your body to dissolve those clots.
So I think, we've talked about TXA and GI bleeds in the past. There's some literature that says we shouldn't do it. My thoughts on that is if you look deep in the literature, that there was some issues with that study. So for me personally, the patients that I work with, if someone has an acute GI bleed, bright red blood coming out the mouth hole or the backside, and it's been going on less than 3 hours, and they're hemorrhagic shock, they get TXA. Any other GI bleed probably did not get TXA because it's probably been a slower roll of that.
Yeah.
So, but variceal bleeds are bad. If someone's having one, you can have your hands full, you can be cath saturated. It's gonna be sit them up, passive O2, manage the airway best you can, and get to a place that can stop that bleeding. Those guys doctor it. Yeah. There was a question that came to me by text, and it was talking about when do we go to the ER versus to the OB-ER, which would be the MEU or OB receiving at UAB. Other hospitals have them too. And I would say if the complaint is strictly OB related, you go to that OB receiving facility at the hospital. If it's not, if there's a fall, there's an injury, there's an airway, there's anything else, you go to the ER. If in doubt, go to the ER, right? The caveat to that is don't take an OB patient to a hospital that does not do OB services. So in our region, St. Vincent East does not do OB. Shelby does not do OB. Princeton does not do OB. So don't take a 37-week pregnant lady with a prolapsed cord to an ER without an OB doctor. One, you'll get fussed at, but who cares? Two, a bad outcome may happen to the mom or the baby. So they got to go to a place that has OB facilities because my skills at delivery are as good as your skills are at delivery. If they need somebody more than you or me, they need an OB or OB surgeon, right? And that's only in our area would be UAB, St. Vincent's, Brookwood, or Grandview, unless I'm mistaken. If anybody online has more information, please reach out and let me know.
Yeah, and I think, over the years, there's been really hospital-specific guidelines, particularly at UAB. I think they probably still exist. If it's 20 weeks or more, they go to MEU.
I think for now, it's 16 weeks and above. They go to MEU, but a lot of times women don't know how far along they are. And they come back.
Don't need to miss that if the patient's been in a traumatic accident, is having some other medical complications like difficulty breathing or chest pain. I don't, to me, if they're 30 something weeks and they're having difficulty breathing, they probably need to go to the main ED. But I'll let you speak for that.
Again, I think most of the ERs in our area, you're going to end up going to the ER to get to OB anyway. So they can do that screen there and let you know the appropriate place. In the Brims region, UAB is different with two different buildings, right? So talk to the radio room. If in doubt, go to our main ER. And we can always move them to the OBER once we do our screening exam and manage them if need be.
We can very easily transport them through the hospital to get there, pending your state.
Should not be sending that pregnant patient that also may have a PE or something like that to the OBER.
Right. The other thing I find that people aren't aware of, and we should all be aware of it, is if we're going to imminent, which is in a separate physical location, maybe for the ED, that if you call ahead and it's a complex or imminent delivery, there's a room right inside the ambulance to the left that they can set up for you. But it's going to be locked and there's not going to be anybody in it unless you call ahead of time and tell them you need that service. So otherwise you can find yourself trying to care for one or two critical patients, right? Pregnant lady and child in the elevator going upstairs to the maternity evaluation unit or MEU. So it's important to give them that report. So even if you call the radio room, right, they call ahead for you. If you have changes, you need to have the number to MEU and be able to tell them that.
Right. And use the big words. Imminent delivery, the head is out, prolapse cord, need help downstairs now. Okay. And I would try to reach out and get someone from the UAB side to come chat with us about some of the logistics as well. That might be beneficial.
Yeah. Did anybody else in the room have any questions?
Let's talk briefly. There's a bunch of crazy people that want to deliver at home with midwives now, with no pain medicine. Where do we stand on that from licensure?
Right.
If we run into that.
Right. So to clarify, there are some people who make the option to have home deliveries, which may be appropriate based upon their appropriate beliefs. Okay. So that being said, that is happening more and more. The problem with that is that some of these folks are not getting prenatal care and then being complicated deliveries or a water birth, and EMS be the first ones on scene, right? Then you got two patients that can have issues. There's no way to address that. It is allowed outside of Alabama legally. Our job will be to get there, assess the patients, and manage them as best we can. I would argue that new deliveries, mama and baby go in the same ambulance, and we try to get them to labor and delivery to manage mama and baby. If not, they go to an ER. We're lucky in the Brems region because you can go to UAB, they'll take that. Some of the smaller community hospitals are more challenging when they don't have OB services or 24/7. So it's tough. And the way we address that is with more training, OB related emergencies for EMS providers, which is challenging because we're trying to get people into these facilities where hands-on clinical is hard to do. So we're working on that from a regional standpoint, but don't expect any exceptional opportunities anytime soon. And that's that.
Yeah, there are some OB players around the area that are helpful, but they're not nearly as good as the real things of experience.
Yeah.
Yes, yeah. So coming up on April the 5th, 4th.
Yeah.
Well, we need to find out which day it is. We're gonna have an open lab. Part of that's gonna be.
It was the 4th, so I got on my calendar.
Okay, April the 4th at Jeff State Cooper campus, the nursing building. Be doing an open scenario lab. We will include OB.
Right, so we'll be delivering plastic babies and talking about emergency situations.
If you have baby, does mom hold baby on the stretcher?
If baby is not dying, yes, that's the best way to do it, right? So if baby is blue and bradycardic, no, we're doing passive O2, chest compression and ventilations. If baby looks okay-ish, baby goes on mama. Okay.
And in an appropriate DOT restraint device. As per the state of Alabama. They get those a couple years ago, a lot of departments have them. Baby can be restrained on top of mama, that device, or to the chair. So the danger is, if you're gonna go lights and sirens and you hit the brakes, can we trust mom to hold the baby and the baby not be injured? And no, we really can't. So that's an issue. So that's always a complicated question. It's been under debate for decades. I've done it both ways. You kind of got to assess whether or not mom's gonna be able to hold the baby. I would say if you deliver on the scene and there's no complications, there's no reason to drive urgently to the hospital.
Yeah.
In fact, very carefully.
Yes. We have a cool question up there.
No, just comments, it's okay.
Okay,
As far as,
That needs to be shared with.
okay.
All right.
All right, on that note,
Well, we've got more people chiming in here. Pain management for childbirth in the pre-hospital setting is one question.
yep, so post-delivery, whatever you want, fentanyl, morphine is fine. Pre-imminent delivery, remember that stuff will go to the baby and it may suppress the respiratory drive, so be wise.
Yep. Okay. The other one is, do we take medical orders from the midwife on the scene?
They do not have a med control number. No, do not. If they give you reasonable advice that you agree with, sure. If they don't, you have online med control, you call. They cannot give you med control numbers, or orders, sorry.
All
I'll
right.
be quiet and let you answer. I got pumped up.
Next question. Next question is, what time is the open lab at Jeff stated? Said we're gonna start it at 9 a.m. I believe.
9-ish.
9-ish.
We'll put it on Facebook. How's
Yeah.
that sound?
And the last one is, hey, what did Dr. Ferguson say about the challenges smaller hospitals present about going to them with labor and delivery cases, especially advanced labor and delivery? And that's from Anonymous. So that's probably like the president of Princeton or somebody
Yeah.
asking you that.
So I think if they don't have, if they don't have labor and delivery services, you're probably better off moving down the road to get to a place that does. If they don't have labor and delivery services and your task saturated, things are going south and it's 30 minutes down the road or going to that ER to get help, you're better off delivering in the ER with that doc helping you and y'all working together and then moving them down the road and having a bad outcome in the ambulance. So those are things you need to think about where you work and have those planned out. So at 2 in the morning, you know what you're gonna do, know whether you're gonna bypass or go to the hospital. My point of that statement was if someone is having a complicated delivery, they probably need OB services more than an EMS provider or an ER provider. But again, if it's a long road to that OB service, you're better off in the hospital with that doc helping you out than not. Does that make sense now? Maybe.
Time, use your judgment based on the context of the call.
Correct. And have those thoughts planned out now. Make those plans now. Reach out to the local hospital, see what their services are. Reach out to that medical director, the nursing staff. Hey, if we have X patient, and what do we do? Right? Plan it out now.
So Dr. Brown, to answer your question, I don't think we have time for your other cases. Sorry about that.
That's okay.
Thanks, everybody, for being a part of it today. If you haven't already done so, please remember to fill out the attendance form so we can get you your CEU certificate. February the 14th certificates were issued with the wrong date. We have a little bit of a snafu getting the repeats sent back out, but I'm continuing to work on that. So please keep watching your email. Could happen in the next couple of days. And our next EMS challenge is going to be in Enterprise, Alabama. And it'll be a week from today. 1 week from today will be in Enterprise. Also be available online if you're trying to get those last couple of CEUs for National Registry recertification. The password for today's attendance form is Trussville. And if all other ways to get an attendance form fail, you can always send an email to alabamaemschallenge@gmail.com. You'll get an automated reply with a link to the attendance form. Thanks, everybody, and we will see you next time.